Hello, everyone. My name is Noel Said. I am the Vice President of Healthcare Improvement at the American Diabetes Association. Today, I am filling in for our Chief Medical and Scientific Officer, Dr. Robert Gabbay, who's unable to join the session today. Our session today will cover COVID-19 and diabetes, and we have a very special guest speaker. We have Dr. Khunti, who is a professor of primary care diabetes and vascular medicine at the University of Leicester, United Kingdom. He is the co-director of the Leicester Diabetes Center, and he leads a research group that is working on the early identification and interventions in people with cardiometabolic disease or are at an increased risk of developing cardiometabolic disease. Dr. Khunti is a leading researcher and figure in diabetes and COVID-19 and diabetes. He was among the first to identify the disproportionate impact of COVID-19 on ethnic minorities. Dr. Khunti, thank you so much for being with us today.
Thank you very much for those kind introductions, Nuha, and also to ADA for giving me this opportunity. Real honor always to work with ADA.
Of course, always a pleasure. We have a lot of questions for you today, Dr. Khunti, and we will try to get to everybody's questions. We have questions that are already ready for you to go.
Okay.
Are you ready? Okay,
we
perfect. So the first question is, what do we know about vaccination in people with diabetes? Are vaccines equally effective? Is there a difference in the immunological response to vaccination in people with diabetes? And does this impact in any way the timing of boosters?
So it's a really, really good question. There's a number of questions there. First of all, we know vaccines are effective for everyone. In terms of people with diabetes, they are equally effective, but there's some interesting data that's coming out recently. There's two publications quite contraindicatory. One is saying that if the HbA1c is not well controlled, then you get a worse immune response. The immune response isn't as good. While another paper just came out last week that showed that the response may be equal even when the diabetes is well controlled. But I think overall, I would suggest that everyone should be having vaccines, first of all, because we know people with type 1 diabetes are about 3-fold higher risk of getting COVID mortality. And people with type 2 diabetes have about a 2-fold increased risk of COVID-19 mortality compared to the background population. So just for that reason, it's important. In some terms of vaccine waning, haven't seen much data for vaccine waning, but there is data coming out for the general population that we do know vaccines start waning after about 4 months. So if there is a need for a booster and you're called for a booster and do your booster, I would definitely have the booster. But the good positive thing is that even when the vaccines are waning, the risk of hospitalization are still reduced by about 90%, even with the waning.
Okay.
What we're seeing is people are still getting some mild symptoms or getting symptoms bad enough for them to go to emergency department. So vaccines, no doubt, for every population, even with people with diabetes, do work. And the other important thing is obviously the carers as well. People who are living in the same households and carers of people with diabetes should really be immunized as well.
Thank you. That's very helpful. And there's a lot of data coming out suggesting COVID is leading to new cases of diabetes. What might be the possible mechanisms for type 1 and type 2?
So this is not a new phenomenon. First of all, I think a lot of people getting excited about it, but we've seen this in previous viral infections, previous SARS, Ebola infection. They have been increased risk, and the mechanisms are not quite well known. And we wrote quite a comprehensive review on this in Diabetes Care recently, and there are a number of reasons for this. One is that these people already had diabetes, and they came in and they were identified as having diabetes because they were admitted and tested for it. Second one is that people who are admitted with acute illness do get insulin resistance. And we know from previous data, for example, most of the data, early data came from people who were admitted with myocardial infarction. They get insulin resistance and they get admission hypoglycemia. The third one is that people who are admitted since the recovery trial are getting steroids. Certain populations. So obviously, if they're getting steroids, they're at higher risk as well. And the final one, which we don't have an answer for, which is the interesting one, is that the entry point for SARS-CoV-2 virus is through the ACE2 receptors, and there are ACE2 receptors in the pancreas, and whether SARS-CoV-2 attaches itself to the ACE2 receptors and somehow destroys the beta cells, and that leads to type 1 or 2 diabetes, because you get complete destruction or not, we don't know. That's an unanswered question. In terms of the recent epidemiological data, the first one that came out was recently from CDC about 4 or 5 weeks ago. Very large database study, and they observed a higher risk of new onset diabetes, and they didn't specify type 1 or type 2. Mm-hmm. But they just said new onset diabetes compared to a control population. There's been a German study that also has shown something similar, and another study that's come out recently showing about 20% increased risk of type 1 diabetes. Mm-hmm. There was a publication in Diabetes Care as well. And we've seen this recently. There is a signal in the UK data, and we're just analyzing that at the moment, is there is a possible increased signal with type 1 diabetes. Now, again, we don't know whether these are people who were prone to getting type 1 diabetes, because there is sometimes a delay, as you know, even in type 1 diabetes before diabetes becomes symptomatic and they get the diagnosis. So there is this prodromal period. Mm-hmm. And whether this prodromal period is accelerated for various reasons, we don't know. So early indications are there may be an increased risk, but it's not definite for sure. And the mechanisms we're not sure about.
Absolutely. And I know this is all, all of this is early data, but I mean, have you seen any evidence on whether the newly diagnosed individuals with COVID and diabetes have any different disease progression or outcome? No,
no data on this. Now, this is, if we look at epidemiologically from previous such data, there isn't much long-term follow-up from people who had previous infections, or even people who were admitted to hospital with myocardial infarction, because whether this disease pathology is different to your normal onset, we don't know. So I think what we'll need to do is follow these patients up longer term, whether it's transient or not, first of all, mm-hmm. whether it's more aggressive because they get the insulin resistance. If they're admitted to hospital and they get severe insulin resistance, that may accelerate some of the detrimental effects that people with diabetes have on top of the new onset diabetes. We really don't know. So I haven't seen any data for that as yet.
Interesting. How about people with diabetes who have micro or macrovascular disease? Are they at a higher risk?
There is some data certainly coming out, and we're working with a French group. So it's a UK, France, US, and Spanish collaboration. And those data are certainly showing that there is an increased association with microvascular complications. One of the biggest risk factor, and this is for cardiovascular diseases as well, is EGFR. So people having CKD, certainly much higher risk. There's some data on neuropathy as well. We haven't seen much data on retinopathy yet. So we'll have to wait and see whether that's also associated. But certainly these are, for whatever reasons, whether it's because the duration of diabetes, whether it's because their risk factors aren't controlled, and that's why they've had the microvascular and macrovascular complications. But these people are at much higher risk. Whether it's causal pathway, we don't know.
Very interesting. With all that said, we have a question. Still some people with diabetes are reluctant to get vaccinated. How might we help them in primary care and endocrinology?
I think this is really for any vaccine hesitancy is discussions. And having a dialogue with them, and they need to know all the data. And most of the reasons for people not having vaccine is they're not sure, they are afraid, they're worried. I don't see many who are completely vaccine hesitant, who are just never going to have it. Most of these are in a transient phase. They're still making their mind up. We call them vaccine hesitant. They're temporary. And majority of the patients, and we've seen this again, where we look at the data for the UK, 80% were immunized initially, and we had difficulty getting the other 20%, but now it's gone to over 90%. So with time, with discussions, with the evidence, all of that helps. And I think it's up to us as healthcare professionals to ensure that we're getting that data out all the time. And Twitter is a great way. A lot of people are putting good data on Twitter to say anything new that comes out, just to reassure the population out there who are still haven't made their mind up.
Yeah, that's wonderful. I love how you phrase, that everybody's in a transient state. Yeah. That helps us shed our own biases about how people feel about, yeah, absolutely. And there's a follow-up question from Sarah here. She's asking if there's data about the time frame for the new onset diabetes. Does it happen immediately upon infection, or is there a delay? Is there any data about that?
We haven't got much on time frame. We haven't got data to that level. Most of these are large database studies. And basically, they just look at a population that was pre-pandemic. So look at a population in 2019 and compare that to the pandemic population, or comparing it to another viral infection such as pneumonia, influenza, or someone with pneumonia. So those are the type of control population studies they're doing. Timeframes aren't there. But we do know patients who are admitted to hospital, there's quite a large proportion, 20-30%, who get admission hyperglycemia. Mm-hmm. So we know those straight away. They've had an admission hyperglycemia. Now, again, the reasons for that admission hyperglycemia, we're not sure. It could be, again, because they had diabetes before and they weren't identified. It could be because of the insulin resistance. But the protocols within hospitals say that we need to manage the admission hyperglycemia. So we'll bring the glucose down with insulin drips, but the follow-up data on these patients isn't there as yet. Wonderful.
And I know you write about post-COVID, and you have an interest in long haul COVID. Any new information on that?
Yeah, so long COVID is definitely a phenomenon. A lot of people think it's psychological, but we've looked at the data, and some good data where we've got a control population without having a positive infection. They do have symptoms, but it's not just the symptoms that's the worry, it's the organ damage. And we've done the studies, and others have done study that people, once you are admitted to hospital, initially we were having about 30% mortality of patients who were admitted to hospital, which has gone down to about 15% or so now, and even less so with Omicron. Once patients came out, and this is from the first wave, once patients came out of hospital, within 140 days, 12% were readmitted to hospital. 30% were readmitted and 12% died, even after they came out of hospital, 12% died. And the ones who were readmitted, they certainly had new CKD, new liver disease, new myocarditis. And again, when you look at the data for myocarditis, a lot of people are worried that they get myocarditis after a vaccine. Coming to your previous question, the risk of myocarditis or myocardial infarction after having COVID is about 10-fold higher than because of the vaccine. So long COVID is definitely a true phenomenon. Most of the symptoms data we have is up to 9 to 12 months. We haven't got any longer term data, but fortunately, a lot of the symptoms seem to improve after 9 to 12 months. There'll be some who will still continue, but we haven't got the longer term data for that. Separately for diabetes, whether people with diabetes have higher or lower risk of long COVID, we don't have data for that.
Mm-hmm. Very interesting, and we'll learn more as time goes by. We also have a question. Can you explain the worst outcomes of COVID among ethnic minorities, especially African Americans with diabetes?
So there are a number of people who are at increased risk, elderly, deprived populations, male sex, people with comorbidities, and ethnic minorities. Now, it's a real complex phenomena in terms of ethnic minorities. We've done quite a bit of work in this area. What is it that's explaining this? Genetics we get out of it. I don't think there's anything genetic related, but it's really the social determinants of these people. It's the ethnic minorities. First of all, they live in more deprived populations. That's a higher risk. They live in multi-generation households, so you're passing the virus. They're living in poorly ventilated small housing, so you get much virus within the house, in the household. They have more outgoing key worker roles, not just healthcare, but I'm talking about in food industry, taxi, etc. So they're coming more into contact. If they get the virus, they're less likely to seek help, less likely to isolate because they may lose their job, they may not get the payment, so they continue to work. So there's a number of factors that are associated with increased increased COVID in ethnic minority populations, but it's very complex. I don't think we can tease out which is the key factor. We do know recently, our most recent data went into medRxiv today, showing that over time the disparities have improved. So when you adjust for everything, the deprivation, key worker roles, etc., the risk is attenuated. And when you adjust for vaccination status, then really, especially for Blacks, we don't see any difference between whites when you adjust for vaccination status. So not being vaccinated is one of the reasons at the moment, not early on in the pandemic when we didn't have the vaccines. But the risk in the UK, Bangladeshi and Pakistani population still remains higher than the white population, even after we've adjusted for everything.
Interesting. And there's a question specific to Leicester. You know, if you have any successful strategies in engaging people with diabetes in underserved communities.
Yeah, we can talk about that for hours, but I won't. So I think what happened with the pandemic in the UK is there was a top-down approach. Do it this way. And Leicester, we were the ones that were in the lockdown the longest. We were because we had such high rates. And the way we got around this was the primary care, GPs, the hospitals, the researchers, and the community worked together. And we identify strategies to say, what is it we need to do locally? Because we know our local communities better than anyone. So working through faith groups, the inner city small voluntary organizations, that's how we got increased vaccine uptake. That's how we got more people tested and traced. And we brought our rates down much, much quicker. So I think it's so important to work with your local community.
Absolutely. Thank you. And there is a question about children with getting COVID from in type 1. Any data or relation with celiac disease? You know, has this been looked into?
I haven't seen any data, but we do know. So we developed with the Oxford group a Q-COVID risk score. So who are the highest risk? And I think celiac is in that, but I'm not sure whether it's a combination of celiac with type 1 diabetes or not. So unfortunately, no, I don't have any particular data.
And I think there's a question that was asking if you think the impact of COVID affects blood vessels in the pancreatic islets.
So that data I haven't seen, postmortem data I haven't seen, but we have some postmortem data that there is the pancreas is certainly affected. Whether it's directly through, as I said, the entry point or not, the tissues surrounding the beta cells are certainly affected, and there is some postmortem data on that.
That's great. Thank you. And someone is asking about sleep apnea, you know, and diabetes. Is there a higher risk in this particular group? Do you know of any data?
So sleep apnea, I'm sure, I haven't seen the data on sleep apnea, but I'm sure it'll be a higher risk because these are, you know, when COVID came through, we were thinking that it's going to be a respiratory disease. People with asthma, chronic obstructive pulmonary disease are the ones who are going to get affected. Certainly, we found out it was the cardiometabolic diseases, cardiovascular disease, heart disease, strokes, CKD, diabetes. And that's the reason I got interested in it. If it was COPD related, I don't think I would have been that interested in it. So we think all of these conditions will lead to worse outcomes for these patients.
And what are your thoughts on Omicron, future variances?
So I think Omicron, we've been lucky that literally, I don't think this is a natural course of the pandemic. I think we've just been lucky that Omicron hasn't been able to evade the vaccines and the natural immunity. But the more virus that's in circulation, the higher the risk for mutations. So we're not completely out of this as yet. I think, we've got a bit of breathing space at the moment. We've got 60,000 cases a day here still in the UK, 180 odd deaths today, COVID related, and we think everything's back to normality, but it's really, we shouldn't be going back to normality. There's so many simple things that we can do, even with Omicron. Masks, social distancing, hand hygiene. These are simple things, and if you look at China, they've been doing this for years. It's from their previous SARS pandemics, and they've learned from this, and that's become the norm for them. And I think for now, we should make that our norm as well. No matter how restrictions are lifted, we should continue all the simple good things that we can do.
Absolutely. And we have, a few more questions. Someone is asking if there is any data regarding resolving long COVID symptoms with COVID vaccination and boosters.
Right. So this should be, there is another, if you go to Office of National Statistics website, there's a paper on there. So we've been working on that one. That's with a journal at the moment. That does show that if you have a vaccine, you have a reduction in long COVID symptoms. Mechanisms we're not sure of. And this is a control study. It's not just a before and after observational study. There's a control group in this. So that's the best way to do some of these studies. And that does certainly show that you do have less long COVID. And there's a review that's come out today from the UK, a rapid review. And that again is suggesting that you do have lesser symptoms of long COVID if you've been vaccinated. So again, a good thing to get vaccinated just for that as well.
That's wonderful. And there is a question about children. If you have any observations about children aged 10, I guess, or below, MISC average age is 8 to 10.
The most positive thing about children is that they have been affected, but not severely. They haven't had the worst outcomes. Thank God for that. When we looked at the data right at the beginning of the pandemic, there was a huge number of deaths in people with type 2, elderly. We didn't see any deaths in type 1s, and sadly we have done since that. But most of them have some other conditions, often associated or not associated directly with type 1 diabetes.
There's a question, I think it's alluding to the risk of being well controlled, vaccinated and boosted. I believe this is the case of someone who's teaching, so indoors with many students.
Yeah, you're well controlled, vaccinated, you're boosted, you're still at risk because you're coming in contact with lots of people, especially if you're a school teacher, you're going to have lots of asymptomatic disease. And this is where ventilation is so important, having CO2 monitors in your classrooms, opening windows. And again, mask wearing, if it's possible to do so, I would encourage that.
Absolutely. And, are there any signals or data that in people who are developing type 1 or 2, that they would have pre-existing autoimmune diseases as thyroid or rheumatoid arthritis in the data sets that you're aware of?
Not seen any of that at all. I think there's a type 1, what we're seeing is there is a slight increased risk, and whether this is just, whether it's related to the autoimmune acceleration, we don't know.
That's wonderful. And then there was one question that's asking for practical advice for people who have COVID and are on oral anti-diabetic medications.
Okay, so when we first hit the pandemic, there was a lot of talk about stopping certain therapies, particularly SGLT2 inhibitors, sulfonylureas, saying, you might be at high risk of hypoglycemia with SGLT2s, you might have a higher risk of DKA, and a number of consensus guidelines came out, and we wrote some as well, and saying, don't change any medications, but when you're in hospital, then if you're admitted to hospital, then certainly SGLT2 inhibitors should be stopped because of the risk of DKA. So then we did an analysis of 2.8 million people database in the UK that we have. That's the whole of the English population. And what we saw was really there weren't huge increase or decrease in absolute risk on which medications you were on, except for insulin. If you're on insulin, your risk is about 40% higher. With metformin, it was about 25-30% lower. For the others, there was a slight increase, slight decrease. But if you look at the absolute numbers, there wasn't a difference. And what we said was not to change your medication because of the pandemic, because all of these can be explained by indication for prescriptions. So if you are young, new onset diabetes, your eGFR is all right, you're likely to be put on metformin, and that's why your risk is lower. But if you're elderly, your eGFR is poor, you're not on metformin, and as I said, eGFR is a risk factor, then you will be at higher risk. So the data to date showing, I don't think there is a risk increase or decreased risk with any of them. We think it's because of indication biases. However, in hospitalized patients, we have protocols, and this is pre-pandemic protocols as well. As you know, if people are admitted, you stop SGLT2 inhibitors. But Mikhail Kosiborod, who's a good friend, has done the DARE trial, in which they initiated SGLT2 inhibitors in patients who were admitted with COVID, with or without diabetes. And they didn't meet their primary outcome. However, it did show non-significant reductions in a number of outcomes, including kidney disease, mortality, etc. And they had only 2 DKAs, and they only identified them because these people were part of a trial and they were being monitored on a regular basis. So I think this mantra that we need to stop SGLT2 inhibitors is something that we will be discussing over the foreseeable future, because there are benefits of SGLT2 inhibitors, possibly even in hospitalized patients.
Absolutely. In your clinical practice, are there any dietary recommendations for people with diabetes who have, COVID? Any special?
No, I think just the same. We know physical activity is associated with COVID outcomes. We know people who are more physically active, they're less likely to have worse outcomes. Even shift worker, we've shown that if you're a shift worker, you have worse outcomes, and that may be related to your previous question on sleep, whether it's related to sleep deprivation or not. But dietary advice, we're saying just keep your normal, healthy diet and your physical activity. Thank
you so much, Dr. Khunti. This was wonderful. There are a couple of questions left, but we are right at the end of the hour. Thank you so much for being with us today. We look forward to more of your research and to meeting with you again to update everyone. Thank you, and have a good night. Thank you. Pleasure. Thank you, Nima. Thank you, everyone at APA as well. Okay.